All right, so good afternoon, everyone, and welcome to the July meeting of the Alcohol and Drug Policy Commission Treatment Committee. My name is Katie, and I am an ADPC commissioner and have the great privilege of serving as a chair of the Treatment Committee. So thank you all for taking the time to join us today. Ashley, would you please conduct roll call?
Great. Katie, I'll mark you as here. Is Bradley here? No, Bradley. Okay, Moxie. I saw Moxie in here.
I'm here. Sorry.
Oh,
Thank you.
you're okay. Christy.
I was drinking. Hi, I'm here.
Oh, great timing. All right. Clara.
Yep, I'm here.
Heather.
I am here. Thank you.
Thank you. Fernando.
I'm here.
Hello. Thank you. Joe. Is Joe here today? What about Mike? Okay. Art.
Art will be here about 30 minutes late, he said.
Okay. Thank you so much. Allison.
Right here.
Thank you. Hello. Katrin.
I'm here.
Great. Lisa.
I'm here, Ashley. I'm here.
Hello. All right. And Beth. See Beth yet? Okay. Back to you, Katie. Did I miss anybody? I don't think I missed anybody. Okay, back to you, Katie.
Awesome. Thank you, Ashley. Do we have quorum?
Yes, we hit quorum.
Awesome. Yay.
Mhm.
All right, so before we get started, if anyone from the public would like to provide public comment today, please let Ashley know through the chat or by raising your hand. We'll reserve time for public comment at the end of today's meeting. And today, today we'll begin with updates from Director Dolph, followed by a presentation from Mitch reviewing current roles, ASAM guidance, and how discharge and transition planning fits with an implementation of the comprehensive plan. And then following Mitch's presentation, we'll spend the majority of today's meeting discussing discharge transitions and exploring where this committee can provide meaningful guidance as implementation moves forward. I also, oh wait, yeah, with that, sorry guys, I'd like to turn it over to Director Dahl for updates.
Thanks, Katie. I love this committee. You guys are our hardest. Well, I don't want to make value statements. You are a very hardworking committee. So Annalise Dolph, I'm the director at the ADPC. I will do some quick updates. The full commission met last month in Portland at oh my gosh. Julie Mine's organization. Somebody has summer brain. We meet again this coming Monday, and we'll be doing a thorough update to the full commission on all of the activities for this 6 months, woo woo, of the comprehensive plan. So that's pretty exciting. If you are at all curious about what's happening in other committees and kind of want to see how it's all coming together, feel free to tune in on Monday. In the other committee spaces, the OYA committee, the Oregon Miracles Club, thank you, Mara. The Oregon Youth Addiction Alliance is meeting later this afternoon. It actually overlaps with this meeting, and our youth recently collaborated with our recovery committee to establish some standards for recovery community centers that serve youth primarily. So that was a neat crossover. The recovery committee is not meeting this month. They're going to take July off. They have been working really hard on those recovery community center definitions. They've developed a standard definition for centers, and they are now working on a set of metrics that they could use as a baseline and perhaps start doing an annual survey across centers so that we can start to measure over time the impact of those centers. So that's pretty exciting. Primary prevention has been just slaving away, working really hard on their Center for Excellence proposal. They've been focusing on the scope of what that Center for Excellence would advise on, what kind of technical assistance and training they would advise on. And next, they're going to turn to governance. And then checking here, one last update from the full commission. We did decide last month to establish an ad hoc SUD data work group. So some of you may cross over to some other work streams that we have, having better uniform SUD data as part of the comprehensive plan. The Opioid Settlement Board also, by its establishing bill, needs to fund an SUD data system. And then there is also work happening within OHA to map SUD data. So we are trying to bring the body of work, so we're not duplicating, and that we are providing infrastructure to move things forward. So the commission is going to be working with the settlement board to kind of bring all these efforts together and to have some oversight and advisory by this ad hoc data work group. And finally, settlement board news, the opioid settlement board is working on an RFGA that will be released this fall for a round of one-time funding. It is overall a fairly small amount of funding. It's like 13.8, I think, or 13.7 million total. And more to come on that. OHA will be reporting out at the August meeting of the settlement board on progress there, but it does seem like they're moving along, and that will be available in the fall, with the hope that all those contracts are finalized and executed for the 2027 to 29 biennium. Thank you, Michelle. And that is all that I have. If anybody wants to correct anything that I said, since I am decidedly off my game today, and happy to answer any questions.
Thank you, Director Dolph. Any questions, comments before we move on with our agenda?
I have a question, just generally, if I could just come off mute here. Do we have any information on, is that going to be that funding 13.5 generally across their funding priorities, or do they have specific other priorities for this money?
Yeah. So they're still in the process of developing, but the board direction is to allocate funding across the continuum. We actually had a meeting earlier today, so it's fresh on my mind. The proposal thus far is to have a minimum amount of funding that goes across each continuum, and then it's like 60% of the funding should be allocated as a minimum to prevention, treatment, recovery, and risk reduction. And then the remaining, there's also going to be a set aside for smaller grants, for smaller organizations or newer organizations that can't handle something bigger. And I think that's 75,000. I think it's 25,000 to 75,000. And then the larger grants, I think, are 100,000 to 500,000. Is that right, Michelle? That's all in draft.
That is correct.
That's super helpful. Thank you.
Thanks for the question, Joe. Anybody else? Awesome. Okay, so
oh, wait, I forgot a committee. Somebody just reminded me. I'm going to get accused of really not having everybody's preferences. Very quickly, if I can, Katie, the Health and Safety Interventions Committee, formerly known as Harm Reduction or Risk Reduction, they are continuing to meet through the summer. And at the July meeting, they're going to be focused on, wow, Mara, my brain is like really not working. Mara, what do you guys?
Toolkit.
Yes, their naloxone toolkit to address all remaining naloxone barriers. And then in August, Senator Reynolds, who's also one of our commissioners, is going to be coming to talk about her proposed bill for syringe service programs to get some feedback from the committee. And we'll be hearing from OHA, Save Lives Oregon, on a recent survey they did and other activities they have going on. So sorry.
I'm going to tell them all that you did that personally. Thank you for the update on that committee. Okay, so next Mitch is going to walk us through the current rules, ASAM guidance, and how those existing requirements connect to the work of this committee.
Thanks, Katie, and thanks for the updates, Director Golf. Also, if you saw my camera randomly mirroring, it was because there's an option now in Zoom to just overlay yourself on top of your slides, and I clicked it and I didn't like the look of it, and I noticed it was bouncing me back and forth. So if you're easily distracted like I am, I apologize. So I just wanted to give you all like a little bit of today I'm going to give a little bit of a presentation about where discharge standards currently exist in rule, how they kind of look in current ASAM standards. And what I would love to do is start talking through what this meant when we talked about unifying and standardizing discharge and transition standards. I know as a group, as a committee, you've accepted the idea of focusing really specifically on different parts of the continuum, but this is something that I think some recent conversations and as we've been talking through the provider assessment has made me really think like we might need to be thinking even a couple of years in advance about like when the best time is for us to pull policy levers to support these standards. So I wanted to work on this earlier. And so Katie, Bradley, and I met to kind of talk through some of the nuances that exist through here. So I anticipate this being kind of a multi-month conversation in the same way that the recovery center's definition and standards work in the recovery committee has went. And that's really so we can think about all the impacts and in particular, a lot of the challenges that will exist in this committee compared to others because we have physical health being a part of our work. So just know that this is building towards later and later things, but I think we've really been kind of talking about for a while. The theme of this year is us taking notice of what's going on in the system, assessing, and then figuring out what we're doing in subsequent years. So please just kind of keep that in mind today. So also keeping in mind that earlier this year, we adopted the EPIS framework to really be thinking, sorry for the big flash of white light. I saw it mostly on Katie's face there. But one of the things that I really want us to be able to do is be making sure that as we start to implement these changes and start to standardize things, we think about like what it is that makes these sustainable. And that's, I think, the thing that during the road shows we heard time and time again is like changes happen, they're hard to sustain, or they happen again. Not that I anticipate us creating the discharge standard that lives on from now until the end of eternity, but really thinking about like, are we setting up something that is too hard to change in the future, is only looking at one level of care, isn't really considering the needs of providers, different providers, and so on and so forth. So I just wanted to put this at the forefront of our mind as well. And also, just kind of as a reminder, this was one of the areas that I think back in April, the committee agreed should just be kept within this committee rather than kicked to one of the work groups to work on more in detail and then come back for approval and review with you all. And I'll kind of explain a little bit of that as we go on to the presentation today. So the first thing, and please use your slides that were sent an email as more of a reference than all of the words that are on these, because I don't think they're going to be as helpful. So I'm going to be kind of talking about general themes for each of these slides. I do encourage, if you're not familiar with specifically the 309.18 rules, to definitely review them. I did include them in full on the next two slides. Those are in your inbox. But in general, there are kind of like four delineations of how we describe discharge. The first of those being in residential care, this idea that there's a transitioning period that begins when a person is discharged from inpatient or residential and back to a community setting. So that's the first time that this shows up. Outpatient, we have that decisions to transfer individuals must be documented, including the date they leave, the reason that they're leaving, different levels of care determinations. And you'll notice like where they went, outreach attempts that they stopped showing up. For adolescents, they do mention that the program needs to be experienced with working with adolescents and be knowledgeable about different developmental needs and those transitions need to be going to ASAM levels of care. And then within our individual rights section, we have that clients, individuals need to receive prior notice of transfer unless the circumstances are posing a threat to the health and safety of themselves or the milieu. Then we have this long sort of other thing describing transfer and continuity of care. And I won't go through all of this, but really these kind of are I would say like structural banding for these discharges. And they refer a lot to ASAM. And so this is one of those big things that I really want you all to be thinking about is how detailed we're going to be in these standards and why, and what does that mean for the providers, and we'll talk more about that too. But again, there's documentation here about where they were transferred, what instances of transfers, the type of services that they have they're eligible to receive or recommended to receive, where their family is involved, a kind of summary statement about how effective their services were. And then in terms of transfer and continuity, this kind of continued piece, they have that the list of the summary should be made available in writing to the person. Where appropriate, there should be a plan for personal wellness and resilience, including a relapse prevention plan. I want to highlight that specific area for you all too, just to really be thinking about of like how are we contextualizing the differences of somebody transitioning to, let's say, a recovery center or recovery support services, or in the new ASAM 4 world, this may be indefinite opportunity for recovery maintenance care, but also for folks that are maybe just needing harm reduction who aren't ready to make like the ultimate change to their substance use as well. And so those are things that we've talked about trying to capture and will be hard for these standards. The other thing that they mention here is that we should be identifying available resources that are there to assist the individual and the family. I want to cue you all into that because of some other things that have changed within ASAM. The referrals to those follow-up services. If somebody just leaves, this is kind of the ECA thing, that we have documented outreach efforts, and that all this is doing so within confidentiality law. So one thing I want to call out before I move on to what ASAM says is, as I was looking through these rules and then kind of went back to co-chair Bradley and was asking, hey, where in the hospital rules should I find these things? And where in the physical health setting should I find these things? And one of the challenges is those are really not going to be found in rules because of the multitude of healthcare scenarios that exist. There are some standards for things like cardiac care that we could look at and things to model off of that, but that's going to be a major difference for our work too. Discharge and ASAM, however, references 4 definitions as they kind of work through where somebody might go and why that might happen. So those 4 words are adequate, available, integrated, and sufficient support. So, and sufficient, just to make sure it didn't sound like I said insufficient. So adequate refers to people that are referring to services and support that promote stability and treatment participation. So really it's a continued need. Available is things that can be accessed during a care transition. So waitlist services, for example. So these are the things that you're going to be recommended that will keep people at a certain level of stability or severity, or just are, maybe they're examples like a recovery peer who helps with basic needs in lieu of services or something like that. Integrated means individuals that are referred to within the program or are through some sort of formal, like an MOU with another program. So how are you really trying to make sure that people get all of those complex needs met in an environment that means either you are employing that person or not? And then sufficient support, which is you're referring them to natural support. So their home recovery environment, a recovery residence, or professional support in a living facility, which one of the things that I'll definitely say is an interesting kind of cool thing to see in ASAM 4 is how much and I think I'm highlighting this because it's come up in this committee space a few times, especially when we've been talking about the provider survey, is figuring out how we're also meeting the needs of our more challenging or more kind of complex case needs. For example, the DD population that I know everybody here was like, let's make sure we're not missing those folks in this survey. So ASAM 4 definitely is trying to be inclusive of that information. And that, again, poses some interesting, like, how detailed do our standards get? The other thing that ASAM says is that this is providing a standard for three different options. Either they're continuing at the surface level, so we're justifying this is the right level of care, they need more care. We're saying, we're not actually reaching the stability, or things have become more unstable, so we actually need a more intensive level of care, or we're transitioning down to an less intensive level of care. The other thing I'm including here that's worth kind of noting is that this is now a range from level 4 to 1.5. There's one exception to this rule, or to this framework, which is that ASAM does say that anybody in level 1.7, which previously, for those of you that have been with ASAM for a while, was like the OTP 1.0 level of care. They do say that there's only one exception to this rule, which is that 1.7 should not be made available contingent upon behavioral health services. So they don't want to lock people out of medication because of their behavioral health needs. So that's something to think about. And then level 1 has been renamed to long-term remission monitoring that recommends things up to, quarterly checkup appointments, which I think is going to be an interesting change that isn't necessarily part of this discharge and transition standard conversation, but I do think as the SUD teams start to look towards how they're going to implement ASAM4 in outpatient settings, that will pose a lot of questions for providers about what it means to have a client open for an entire quarter that you might not see, when traditionally people have generally said, like, we'll close after 30 days. So that's an interesting window that opens. In addition to those ASAM standards, the things that are already in rule, there is also one other thing that I wanted to make sure that folks knew about. Back in February, Jennifer Poor came to give an overview of the SUD 1115 waiver. And one of the requirements that it does exist within that waiver agreement was that the state does need to define requirements for continued stay, step up, step down, and discharge based on the ASAM criteria. And then the care coordination transition planning should also be included in these standards across all levels of care. Now, the interesting thing about this means that we have to have a standard. They also say that the standard can just be deferring to ASAM in this. I'll kind of pose the question early that I think we're going to be wrestling with for a significant portion of today's meeting, which is that enough? Because I've heard I think there's a mixed bag of feelings about, like, where our administrative rules do help or support or kind of reinforce the best care standards that you all want to see. I think our priority area around quality and accountability raises a lot of those questions about, like, what that balance looks like between prescriptive guidance versus, like, a simplified and streamlined guidance. This is something that I did take from the ASAM4 implementation team, actually, because they're wrestling with this too. I know there's a lot of talk about admin burden, and particularly around this sort of thing, we have an opportunity to either be way too restrictive and not get any benefit, or if we're way too lax, we might not see any benefit either. So this is an interesting teeter-totter that I'm excited to kind of have that conversation with you today. And then this is something I've been sitting on for a while, kind of waiting for, like, when to share with you all. But functionally, this is kind of what we're doing today. Is we're going to be kind of talking about what this discharge standards a little bit in the center here means. But realistically, like, what we do as the ADPC, what you do as a treatment committee underneath the ADPC, is cast a vision over 14 state agencies. We don't always get to necessarily directly impact those policies. Sometimes it's our agency partners are like, yep, that's super awesome, let's do that. And sometimes there's reasons that we might not know that those aren't happening, or the mechanisms of doing those things don't lead to change fast enough. And so kind of if I'm to really reduce this to a simple way of thinking, there are two ways that agency policies really kind of, like, impact the care down at the service level, which is either through funding or regulation. And that regulation can either describe how care looks, prevent certain things from happening, permit certain things, or require certain things. On the funding side, maybe it's supportive, it inspires, incentivizes, or prioritizes certain actions. And then really the question that I have for all of you today is what are we hoping to, like, what is this vision that we're casting that we want to see eventually impact those two arms of what state agencies can do? Because what we know is that evidence does define how our care continuum works, experience does inform how that can act and look. But ultimately, we have to, going back to that EPIS model, figure out how do we kind of bridge through those connections. So, the last two things that I have to show you before we move into discussion are the kind of starting point of what we all said where we were starting, our near term, midterm, long term, and our ultimate goals around transition and a more kind of consistent form handoff. So, at a starting point, what our road shows, community engagement, work with the committees and the commission said was that discharge is often based on program rules rather than clinical and recovery goals. And at the ultimate end, I won't read through all of these, but we believed that improved recovery outcomes would happen and there would be a reduced recurrence of care episodes. The way I'll kind of throw this out there is the feeling was if people didn't fall through the cracks, then we wouldn't lose them, and that we might actually kind of see like a more rapid recovery. So that's one thing that I want you all to kind of keep in mind as we have this discussion today is like, what does it mean for us to go from these really program driven outcomes that are just saying like, well, you did X, Y, or Z, so sorry you're not here anymore, or you succeeded because of X, Y, and Z. But for us to know, like, you went to a treatment program in the state of Oregon, it probably means this. To get to the point of, let's just say in the midterm, where there's increased follow through with these community reintegrated supports. The next one of those was an expanded use of cross-system care coordination protocols. You'll notice that I'm lumping both these conversations together today because it feels like we live in kind of two different worlds within the SUD treatment space, which is that ASAM says we don't really discharge people, we transition them. Our practices say we discharge. And so like figuring out what it means to like functionally do that differently, I think is going to be a fun thing for us to write in some sort of standard form. But again, very similar to the last thing, there's a disconnection between the referral, confirmation, and there's an inconsistent follow through with discharge. The ultimate goal being that we would have a continuity of care, there would be a reduced drop off. These two feel almost like inherently linked. So that's why I kind of went through the discharge and transfer rules. So my big questions for all of you today is what does standard discharging planning process mean? This is also where I'm going to tip the hat back to Katie and I'll turn off slides and I'll take a lot of notes and I'm going to try to do some wordsmithing and stuff as we move through these next couple conversations over probably, like I said, this month, next month at least. But what are the levers that we need to impact this in alignment with the plan? Is deferring to ASAM itself sufficient? Why or why not? And is there anything that because again, we're still building that survey in the background, is there anything that you think, given the conversations we've had about the survey, that will help us understand this more innately? And I see Fernando's hand up, and Katie, it is back to you, and I'm going to hide my slides.
Yeah, thank you, Mitch. I agree. Those two, we have to do them together. I was wondering, one of the things I've noticed over the years when we kind of go into stuff like this is sometimes competing definition of words. And I was wondering if we have like a glossary that we can work off of so that we are all kind of using the same terms for this discussion. Or at places where because even in the OER, sometimes there's conflict in the words. And so I was just wondering if we have some sort of tool that we can use to help guide the discussion.
I'm happy that you've asked this question. Sad that my answer to this question is not yet, but so earlier at the start of this meeting, Annalise mentioned the data ad hoc group. There's this other group that I'm a part of that I hopefully over time you'll hear more and more about called Mapping and Recovery. The group that I lead is specifically focusing on trying to unify data definitions and those other definitions, even if it's just to figure out what that list of to-dos is, to figure out how do we do that. So hopefully I'll have that to you sooner than later. Now that said, do you have a proposal for like what that word should mean for today's conversation, just so we all understand that? I think that would be totally fine to do.
I guess my proposal would be is if we're gonna latch on to a specific item and discuss that we have a sort of working definition that at least we're using on that definition. Because I also noticed in the slides you use section 309 of the OERs, but not 415. I was wondering if there's a reason for no 415 and stuff like that. So
I want to say, and I'm going to put my foot in my mouth if I'm wrong. I think it referred back to 309, which is why I only included the 309, as it like looked the same, but I'll double check that. Um, yeah, but I'll find that out.
Thanks, Fernando. Always keeping us on our toes. Someone's got to do it. Okay, well, thank you, Mitch. I appreciate you walking us through both the regulatory requirements and the implementation framework. As we move into our discussion, one thing I'd encourage us to keep in mind as we move into I'm sorry, my words aren't coming to me, is that our role isn't necessarily to rewrite clinical standards or regulations. Instead, we're looking at whether the current system supports the goals laid out in the comprehensive plan and where there may be opportunities to strengthen implementation, measurement, and coordination. So again, this is meant to be a conversation, so there aren't right or wrong answers today. And I'd love to hear from everyone around the table. We all represent a different part of the continuum, so it's important every voice is heard. All right, so I'll start with Mitch's first question. When we talk about a standardized discharge planning process, what does that actually mean to you? Should I throw the question in the chat?
I'll start.
Oh, go ahead, Allison. Sorry.
I'm just gonna pre-jazz it. Right. I mean, I think the first thing that happened in my brain was like, are we talking about what are the standardized components of the discharge, or are we standardizing what are you asking me? Are you asking me like what standard things should be in all discharges, or are you asking me what would it look like if there was a standard process? And that maybe I'm that might be an arbitrary place that I'm differentiating, but my first thought was standardizing the components of the process.
That's a good question, Mitch or Heather. Someone. It's a great question. Go ahead.
I was to say that's probably a Mitch question. I had a different comment.
So the fun part about this is I actually want us to be able to start widening that today. And I know that's like a non-answer to your question though, Allison, but I think that my reason for saying standardize it, like what does it mean to do that, is are we just saying like whenever somebody leaves a program, no matter the type of program, here's the thing, or are we saying that like a level 1 program, this is what discharge standards look like, so on and so forth? Like are we like what does that actually mean for us to have a standardized discharge like in the state of Oregon? Because otherwise, like I think, or actually, I guess the other point, by comparison to today, is maybe the other thing to say. So that's like two-part. It's like, what is the difference between where we are right now and what that actually is? Because I think that that's a little amorphous.
So then I'm ready because I had this my comment is we're considering this. Great. Because to Allison's point, as we went through all of this stuff, I think this is one of the puzzle pieces trying to think about when we are talking about this subject, and we talk about this a lot here, a really big piece to a standard discharge system is that we have multiple Medicaid payers and we have commercial insurance. And those as you put on this thank you for doing that when you put it on the diagram,
discharge processes and transitions of care processes. So and so for me, to Fernando's point, I'm gonna say discharge is when the person leaves a program and they're leaving you. That's how I'm thinking about it in this comment. And transition is when they're going to a new level of care and they may or may not be leaving you as the provider. Okay. Those are two different things to me, so I'm going to say that. Those are highly impacted by that funding stream. And I'm thank you for putting it on the chart, because we often don't talk about that, because that's where, in my experience, programs have tried to use their policies and procedures to balance the state regulation, the payer requirements, and the clinical need, right? Because you're trying to comply with all of these activities that make up how you operate your program. And so, that's probably a very broad way to say that, and people could poke holes all over that. But when we're thinking about these things, those are the things you have to think about. Personally, I would always say we should always lean into the clinical, but that is not always the reality. We try, and that's why I say we balance these things when we deliver care, right? Because we're trying, as clinicians, I'm going to say clinicians want to lean into the clinical, but we have to balance the other things too. And so it causes, so I would say I'm thinking through it, sorry, really thinking about making sure that those three things are as synced as possible and support each other, because that's when we get into really horrible administrative burden, is when they are not synced. Okay, that's all I have that's a lot, sorry.
Can you say what the three things are really quick for my notes?
The fund, like on your sheet, it was just what you had on your diagram. The regulations, the payer, I guess that's a different form of regulation or requirement, and the clinical need, right? Those three things. That's the world we work in, and that patients have to experience.
Thanks, Heather. I think, Lisa, are you next? No?
I think it's Moxie.
Okay, sorry. I just see a bunch of hands up. I didn't see who went first. I apologize, Moxie. Go ahead.
Sure, thank you. I think that one of the challenges is that what Heather described really well in detail, and she did that so well, I can be brief, is I think that when patients leave, they often leave under in a distressing situation, and it's pretty chaotic. A lot of the time it's late at night, early in the morning when nothing else is open. We might want to look at night and weekend discharges and compare that with daytimes, just because of the availability of resources and staff. I would love to see us keep track of when the patient actually leaves the building and what they're given and what kind of care they receive right then, because I think that is what ultimately matters for their outcomes. Separately, of course, for compliance and meeting the standards of care for all the regulatory stuff and insurance, I think it would be good to have some other timeline that can kind of take care of both of those. I've had some patients who were, for instance, told that there was trace fentanyl in some paraphernalia that was found in their clothes in a locker, and it was never substantiated. And then they were discharged in the middle of the night to nowhere. That kind of thing happens, I think, unfortunately, more often than we realize. So knowing both what happened right when the patient left and also what does the charting look like. They often have like a window, I don't know, some places 24 hours and others 72 hours to file your discharge note. And so those are two pretty separate timelines. Thanks.
Sorry. I was just jumping on in, Katie.
Yeah, do it. Thank you, Lisa.
Sorry about that. This is my comments really are just kind of
I'm really piggybacking off of what Heather and Moxie already said, but I think we're looking at two different lanes: outpatient program and their discharge, and then obviously residential and their discharge. And it's really hard for me to get behind the idea of kind of coming up with a process when there's not a universal definition that's accepted. So like without a universal definition that really describes the conditions of discharge, it would be really hard for us to make any sort of recommendations. I'm also really concerned about the level of micromanagement coming from the state around processes like discharge. That gives me, when discharge first came up, I just got my gut sank. And I think this could be, we're on a really slippery slope right now. That's it.
No, you're muted, Fernando.
Yeah, I'm really trying to grasp the standard discharge planning process means. And the question that keeps coming up is how do we standardize a process that should be completely client-centered? So then that's what I think is what a standardized discharge planning process should be, is client-centered. The reason I bring it up, I've worked at and I've seen too many places where a person is admitted to treatment because they have an opioid use disorder and they also happen to consume cannabis, for example. And they don't get discharged until they've decided that they never want to smoke cannabis ever again, even though they never said that they are not there to address their cannabis use, and hence they don't get discharged. Also, it is entirely possible to do a treatment plan that says you're going to meet with somebody to two or three times just to discuss if they want to engage in treatment. And if they decide after those two or three appointments they don't want to, you can say treatment completed and discharge them as treatment completed. And that's completely legal and allowed, but it's not something that that it's part of the, out there. So that is just the evidence for client-centered. Client voice needs to be involved in the discharge. This goes also to what Moxie is saying. It's just like, I don't agree with that I should be discharged for this reason, and those sorts of things. So.
What, Allison?
Yeah, I heartily support what Fernando just said, and I think I think Dana and I were thinking the same thing at the same time. It's in the chat now. I think, and I intentionally said transition versus discharge, and maybe we could call them differently, right? Because I come down to trying to think about this as a chronic disease that our rules and our structures continue to treat as these discrete episodes of care. And so we're always trying to figure out how do we weave these things together instead of them being all these stop and start and stop and start. So you should be involving the patient from the get-go in a planned transition care plan, right? Let's talk about what are your goals, what makes sense next, how do we get you closer to those goals, which then means we know you're ready to transition. Not you've been here for X number of days, or you've submitted X number of clean toxicology screens or whatever. Because the word clean, I always try very hard not to do that. Sorry. So it is patient-centered. It is focused on an assumption that you will transition because we recognize this is a chronic disease, and a transition of care makes sense. A discharge would be, I mean, there always, we've been in residential settings. There are circumstances where an actual, just like you cannot be in this environment anymore, is necessary. And so the differentiation could be transition versus discharge. And again, or, some people just bolt. That happens too. And that's no harm, no foul. But I think we start calling somebody ready to transition when they have met the goals that they have defined and that we have had a thoughtful, planned process for what the next phase of care is going to look like. And, that to me captures sort of philosophically, it's not the right word, but that's the differentiation, that it's designing something that is based on the science, that recognizes what ASAM is trying to do and includes the patient. So that would be that's where I would start in terms of talking about a standardization.
Go ahead, Heather. My mouse is not working. I'm sorry. I'm trying to like unmute at the same time.
Yeah. So I mean, I think Allison, I mean, that's transition and discharge are so different in the clinical driver. And I'm just gonna, sorry to drive this point home, but we also have to, in discharge, I would recommend, or I'm gonna ask for people to consider, we also have situations where the payer is determining discharge. And I would not call that transition of care. I think clinicians try to make it look like transition of care. And that is not transition of care. That is an external discharge. Sorry, I'm going to be pokey. And I think we need a mechanism to document that and recognize that that is a fact and it's happening right now.
I agree. Thank you for bringing up that point, Heather, or calling that out. Go ahead,
Yeah. Mitch, again, in the spirit of kind of you're taking notes there, I would love to see something maybe standardized in the language that discharge/transition should be sort of what Allison was saying, should be assumption on day one. So when you are making the treatment plan, you are also supposed to be making the discharge plan. And that the discharge plan should be getting updated alongside the treatment plan as you go. Because too often we've seen somebody in treatment 3 months, they have no discharge plan, they leave, and then when you're going to find their relapse prevention plan, their support plan, you're like, oh, I guess we have to make one really quick, and it's not as supportive as it.
I told Katie I would hop in when all the hands went down because there's a couple things I want. So one, it's so cool that you got to bookend this because the first thing on my list was what I wrote when Allison went off mute first, which I said process that begins at admission was something I heard. So I'm glad you heard the same thing there. I've also heard that this needs to be person-centered, a planned process, not a like random process. There may be two different categories that exist here: transitions, discharge. I'm referring. I see your language there, Joe. I'm going to call it utilization management derived transitions are separate from what folks are thinking. I'm wondering if this is maybe somewhere we would have a recommendation for like a roads tag to be able to differentiate that even like again trying to like get benefit out of the data we're submitting. Now something I'm curious about because Joe had also put this in I'm going to kind of put both of these comments in there back to back actually. I would like to pose these as like challenges to you all though, because Joe asked, what are the drawbacks to us adopting the ASAM definition, which doesn't include discharge at all. They're sort of in the look that this is a lifelong, like, is created as a potentially lifelong need. And then Dana, thank you for being here, by the way, agency partners. Dana mentioned discharges against medical advice would look very different than a thoughtful plan discharge too. So like, how do we consider those two things? But I'm also kind of hearing there's this maybe part of our work in standardizing discharge is also standardizing admission. Like there's got it like that also would have to come with that, or do you think that it is entirely just in standardizing like what is the requirement of successful discharge? Because I'm now kind of imagining for those of you that have been through an audit before, like I'm imagining that process of like you pick your 10 charts and then you're like, I've totally nailed it, and then you realize oh, the transition plan that was created on day one is completely different than day 30, and we don't have an explanation for why. So I just want to throw those challenges at you all. Not that any of this is a bad idea, but I think that these are the things that we're wrestling with. And I'll be quiet again.
Hey, Mitch, would it be worth it? I mean, I guess this is for the group, right? Would it be worth it to instead of saying standardized discharge planning, what am I trying to say? What I'm trying to say is the planning process, let me get my thoughts right because I had it and then I lost it. It's kind of a nuanced question about standardizing the discharge plan, not the discharge process, is kind of what I'm trying to get at. That basically, like we can't actually standardize there's too many variables, including just the client, but we can standardize that a plan needs to be made that includes certain elements that way, right? And so that the plan should indicate like natural supports, like referrals to, and those sorts of things. So that's just an idea.
I saw a lot of nods. Go ahead, Heather.
Yeah, I think that's a good definition, Fernando. And back to what Lisa was saying, and when I'm thinking like how we've been talking about transitions versus discharge here, I think where a difficulty happens in the system, and this is often influenced by the OARs and how they're interpreted at the moment, is that transitions start to get treated like discharge and looked at and handled in a very prescriptive way that isn't very flexible to client need. And one of the good things I think on the medical side of the business is it's a little less that way, because care is delivered as the individual shows up with the need, not through a time or prescriptive regimen, which is what we tend to do here in Oregon with our interpretation of ASAM. So how do we get ourselves out of that knot that Lisa has very nicely brought up? That do we, if we get a more standardized discharge and entry, does that help us allow the transitions across levels to be handled in a more clinical manner, both in our documentation and the way that we're audited, so that it becomes less administrative burden and more client-centered? That would be a great win if we could get something more standardized to give us more clinical freedom and patient voice in the middle.
Go ahead, Joe.
Thanks. I'd like to echo that concern for administrative burden. I feel like we always should keep that in sight, because anything that's too onerous will just end up being worked around, and I think we've seen it plenty of times. So thanks for that, Heather. And then as to the definitions, and I'm in no way advocating, I'm just curious. ASAM doesn't define discharge, but they do bring up some considerations for transition, and they talk about safety planning. And so in that case, I'm feeling like safety planning is maybe sort of moving in the direction of discharges for patient safety or behavior concerns or whatnot. Planning for everybody in that case ahead of time might be something to consider. But the transition of care element, and I agree, they would have people stay at their level 1 indefinitely and bill a code 4 times a year for a check-in, and I'm fine and things are good, and that's that's meaningful for the patient, for the participant, because that kind of dooms them to a forever diagnosis that maybe is not going to be relevant for their life in a few years, or everyone's individual. But they talk about, for transition planning, anticipated level of care. This is planning, of course, and they say it should begin at admission and continue through physical and mental health service needs, medication access, recovery supports, and OD prevention and harm reduction. Those are their 5 categories I see in their online crib notes. So if that's helpful for the conversation, it's all of those feel important to me, but it's definitely not a whole framework of what we're talking about. I do recognize that too. I posted a link in there I found online in chat.
Go ahead, Christy.
This is all it's all really interesting to me because I was coming at this from a totally more micro perspective. So this really broadens my horizons, and I want to respond to like everybody, but I know I can't do that. I don't have enough time. I agree with regulations can sometimes cause a lot of burden, and we have different types of agencies for different reasons. We look at person centered because this person maybe I'm looking at more administrative discharges when people are exited. I don't ever want us to get specific into, okay, well, this person had a drink or this person did this, and now we have a rule where we have to discharge them. That worries me a little bit. I like the broader perspective of starting early, of having more guidelines of how the process should look. There's so many different variables as far as those micro things. Housing. I mean, some people it's as small as getting an ID, or how are they going to communicate, or you know, you've got everything from financial loans to going to school to housing to food to they have a dog and need to get leashes and dog food, and there's so much stuff that I think if we just make this skeleton type, these are what the big broader areas are, and really dig down on it needs to start on day one. It all should tie together to that treatment plan, because so often somebody's discharged with a list of meetings to go to. Here's an AA meeting, here's a schedule, and that's all you get. That's why people relapse. That's why people don't make it to 2 years, because there's all that other stuff that should be addressed during treatment. I mean, my opinion kind of is that once you're in treatment, you've stopped using now, or you're on medications. Now let's get you the things that you need to be successful for long term. And I think that's where discharge planning comes in. So yeah, and I know there's different kinds of discharges, but I think it's all the same information. Even if someone's only there for a few weeks, we can still provide some of that that they need. So there was one other thing, and I don't remember what it was, so I'll come back.
Thanks, Christy. Go ahead, Lisa.
I just don't want us to forget about, when I think about discharge, I just really think outpatient and residential, but I really also forget about the programs that we have, our MOUD programs that are working in with our AICs, and what does that look like when they upon release, right? What sort of transition plan does that look like? And then of course, if they are interested in outpatient, or if they're only interested in MOUD support, and then along those lines with MOUD, what does it look like, or Matt, what does it look like for our maintenance clients, right? Like, how do we identify transition care or discharge care for them? So just kind of thinking off the top of my head, that's also another lane that I think we would need to really talk through. And to Christy's point, I see it quite often in the work out here in Eastern Oregon, where somebody may be medically discharged from outpatient services, right? But there ain't no way they are ready to go back out on the street without additional support. So what does aftercare mean, and what does recovery mean? And are we even the right group to be talking about discharge if we're treatment? Is that maybe more in the lane of recovery?
So one of the things I'm glad that you're bringing up these other care settings too, because I just want to throw out to you, like, what is there any difference that you all are imagining like our physical health partners would need to be considering too? Because in Moxie, this might be a really great place. I talked a little bit with Bradley, but like I know that this is where this gets a little bit wonky too, is figuring out when people only have an MIUD prescriber, like what does that transition to an outpatient provider if people want behavioral health services in addition to their medication? Like those are questions to wrestle with. And I'll also throw out for like obviously for OTPs, there is a like an annual review process that I think like the feds are asking us to go back to, and a couple other things to think about. But like if there are programs where individuals may receive those services for the rest of their lives, like how do we also capture them in this process too, to ensure that we're not creating a scenario where people that receive these longer service models are receiving less client-centered care, by example. Because I think I'll be the person to kind of say something out loud that I'm surprised I haven't heard, which is these standards to a few of you on this call, and I think there's probably a reason that you are on the treatment committee at the ADPC. Y'all read the OARs in a very unified way, I think, frequently, is to say like the OARs are really clear about like what our discharge standards are, which is why ours are like client-centered and all of these things that you're describing. And yet we've said like too many programs are doing things based on what their organization does. So like that's really that bridge. Then going back to the EPIS model is like how do we bring those two things closer and closer together every day? And I just want to acknowledge for those of you that have been doing this well and for a while, I know that this can be an aggravating conversation to try to to think about too.
I have a thorny question. Is that okay? Um, is there any way to tie payment to quality of care and to quality of transition of care, given only situations when the program actually has influence? So not against medical advice and not forced insurance discharge, but I've seen a lot of discharges where, for instance, people haven't been offered any of the FDA approved alcohol use disorder medication, but the facility can just keep admitting people like that multiple times and charging insurance tons of money for really low quality care without evidence base behind it. It's okay, of course, for the patient to refuse whatever they want, but I just would love to see, yes, value-based payment or some kind of way to tie quality care to payment. And I know as far as like program managers and administrators, if we did that, I'd love to hear what all the problems are with doing that and how we can deal with the burdens that might create for the programs. Thanks.
Go ahead, Art.
Yeah, I think that would be a great idea. The challenge that I've seen is supposedly that's what the ICOD certification was going to do, was there's an enhanced rate that you get when you're ICOD certified. But again, no matter what we change or what we do, there's nothing currently in place that you can do that says anything about quality of what it is you are doing. As long as it's in your policies and procedures in your COA application and it's written down somewhere, you can say you're running a DPT group and the facilitator's talking the whole time, which is definitely not how that's supposed to go. But there's no oversight or accountability to quality of anything. And I'm already hearing on the ICOD certification agencies saying, oh, we're ICOD certified. And yet when I start talking to them about intellectual developmental disabilities or what does that mean as far as change of status of clients they can receive, they are direct that it's not changing anything. It's the same clientele they're going to see. They get an enhanced payment. So I think it's a cart before a horse if we don't figure out the accountability piece.
One of the things that I'm sort of curious about is, and because I think we're getting to that point, like I'm hearing you, Moxie, you're kind of saying like, what is the lever here? Or I know you're kind of saying like, what is the accountability measure on the other side of this? And again, thinking about our current world, and I know that this is not the most fun way to plan for the future, but in our current world, you meet the requirements that are set forth in the OARs, and that's what's the word I'm looking for here? Proportional to the amount of findings that exist in those 10 charts and so on and so forth. In that world, like what would need to be different to do that? Because otherwise, like I think we're still describing the same kind of place. Is it that like you would need to have an encounter data that would happen within a certain amount of time that confirms that thing? Like what is it that would actually change that? Because I think that's the thing that I'm sort of like I guess like weighing in the back of my mind, and I'm not saying that any of these solutions that you brought today are bad, and I'm working on like I'm hoping next time when we come back, I'll have that working definition that I'm kind of typing way through these notes. But if we show up and we're like, here's all the things you have to do, I can just imagine people go admin burden, admin burden, admin burden. So like, what is the offset to that? Or is this like, is this truly like, is this because it's looped into the treatment planning? Because I do like that idea of treatment planning and discharge like always being connected at day one. How does that work? Go ahead, Fernando.
Um, in the spirit of a working definition, I would love a working definition of admin burden because officially half of this job is to write notes. We're literally talking about how to write more notes. And so what I hate is when we confuse the admin burden with just your job is to write chart notes. That's part of the care of the client. It's part of the evidence-based practice that for clients. And we have, I'd like to have a definition that differentiates between those two things so that we can actually have some meaningful discussions around this topic. Because, yeah.
I was gonna say, Heather, I know you're on a working group for this, so you might have an idea.
At the moment, I am not, but I have been for many years. Multiple different groups. I agree with Fernando, that charting is where we document our transitions and the client voice and what care we're delivering to meet those transitions and the journey to recovery. The admin burden comes when we're not using documentation as we're not putting that as the primary thrust behind our documentation, and our documentation then becomes the acquiescence to the payer and the oversight body. That might sound provocative, but what I will say is that you can be doing that as a clinician, and then the document is used by the payer for utilization management and an assumption of the quality of your care. And it is also used as the test for the auditing, depending on the interpretation of the auditor who is in your building that day. So that is where the admin burden comes from, is from not the clinical piece of the documentation, because I concur, I agree. It's really, I mean, when I was doing clinical work, that's how I worked with the client, right? and where I was thoughtful about what my next session would look like, and where we did it was used in the supervision process. And that's when it was its best, right? When it was meaningful to the clinical process and to the needs of the client. But admin burden is when all these other things happen, and then things have to be adjusted and refined or defended, or, I mean, just silly things like, and that's why I agree with Lisa that we have to be very careful when we make structures, because the structure will become our pain. It will be our guide, but it also, unfortunately, in the current system that we have today, frequently becomes the pain. As an outpatient provider running program, we were told we couldn't, all of our appointments mostly started at on the hour. We were told that that looked like fraud, so that we should not do it. I kid you not. Everyone in this room can talk about that. The same thing when we put in discharge planning, when we put the required items, which I agree with Allison, ASAM has a nice framework to work from if we're going to choose one. And I think Joe was seeing some things similarly, that a lot of the things he mentioned were in the ASAM already, that they are meaningful to the outcome we want and not additive, because within the system, they can become just another widget to count. And that's when we get into admin burden. I'm sorry if I pontified, but yes, I've been on these work groups for years, and this is where we get admin burden. Yeah. And it's real, but it is from those drivers of auditing and paying.
Thanks for adding that. I would say clarification, but also like separation of like where like we're talking about like operationally administrative things rather than like clinically administrative things. So it's a good like separation.
Yeah, I don't think maybe I'm sure there's somebody who would disagree with me, but the required clinical documentation is required. It should be meaningful and useful. It's all the other stuff that's the admin burden.
I'm gonna write meaningful and useful in my notes. Go ahead, Moxie.
Yes, thank you. As far as administrative burden goes, I wonder whether the state could work with providers to figure out who's using AI dictation and whether that might help with this type of thing, because that's saved me a lot of time. And I also will keep a checklist of what I mean to bring up when I'm with a patient so that it actually happens and gets into the note. Um, Other than that, I think the issue with auditing and the administrative burden, I think it would be wonderful if we had independent auditors. So perhaps an auditor group that oversees all of the OHP programs, but they're not employed directly by a CCO, because any auditor within a CCO has, there's like a kind of a conflict of interest for them to try to claw back money, for instance, from therapists, especially. I think this happens more to therapists than to doctors, where they'll audit and say, we overpaid you based on your documentation. We want that money back. And so if that person's no longer an employee of a certain company, then I think we would have better outcomes, and the cost of that group could be covered by all of the CCOs working together, or all the private insurance in Oregon working together. Thanks.
Thank you, Moxie. Go ahead, Joe.
I feel like I've heard like a theme here around bringing together patient-centered or even patient-led care, along with these kind of standards around what good discharge planning looks like. And I wonder, yeah, as Allison mentioned, and just ASAM in general, I wonder if those are really put to clients along with some expectation setting and clear, description of expectations within a program. A lot of times people are just admitted without any sort of understanding of like, what exactly are the rules? What am I doing here? I don't, a lot of times I'm just going to speak from my personal experience. It's like kind of a whirlwind. You're going through a lot in life and you end up in a program, and someone might put a sheet of paper in front of you and gather some signatures or something. But oftentimes there's not like a really clear, explanation of what expectations are going to be and what is going to qualify for discharge. And, these are very clearly the behavioral expectations of this program and what happens if they're violated. So planning can be done ahead of time. I think there's like sometimes a reluctance to plan for a return to use or substance use or behavioral problems, but there's also like a lot of benefit from just asking people and saying, this is what happens in the case of these type of behaviors. That's going to be the hard line of what's going to happen. But like where do you want to go from there? Like, do you have a place you can land? Do you have do you want to connect with these harm reduction resources? But up earlier in the document, earlier in the chat, I just kind of translated the ASAM transition elements into how I wish like someone would have kind of just talked to me, and I buried them away in the chat. So I just popped them here again at the top. I don't know if they're helpful, but I'm just thinking about this. I got the business lens, and I understand like sustainability and not wanting to cost programs money and things like that. But I think in the end, when we meet people where they're at, that's actually that's the best way of doing business as well too. So I put on my hey, I went through this a couple decades ago cap, and that's kind of what I came out with. Thanks.
Thanks, Joe. Go ahead, Allison.
There's a piece of what Joe said that I right there that I think, as I listed out what I thought would be important components of a discharge plan that I think are is really important, and it's the parallel to me is for any of us who have done a lot of crisis planning or suicide risk planning with people. The idea is you are planning for a crisis when you are not in a crisis, right? So an element of an expectation of discharge planning is because I know he said something very important there. Often our patients don't want to talk about. It's not just that we're not comfortable talking about it. I think especially in residential, you've got somebody who is just like hanging on by the skin of their teeth, and the last thing they want to talk about is what's going to happen when you are tempted to use, or what might happen if you do use. And so I think getting our clinicians habituated to those types of risk, risk-oriented conversations, and getting people in a safe environment like residential treatment in particular, comfortable saying, okay, here's, I'm just wandering into relapse prevention planning, but it's just like, it's more than relapse prevention. It's, let's talk about the reality of crisis, and how do we normalize that? So I would just kind of back to what are the components? I think that's if things don't go as planned, what is the best way to keep you as safe as possible?
Really quick before you go, Moxie, this is something that I also just want to plan to bug in folks here. I'm fairly certain that this tip manual was removed from SAMHSA. So if anybody has it, I think it was tip 62, maybe it was 61. But it was new new counseling competencies through SAMHSA a couple of years ago. It was in the previous administration. It included a level of detail that had like counselor, and again, I'm not saying this is like a standardized practice or anything, but it kind of speaks to what you're saying. Like it required counselors to be able to describe like here's how you flush your needles with bleach water, to be able to re-sterilize them and things of that nature, to be able to support those like very dire and intense conversations. So I think there was a point in time where like the powers that be were looking at kind of describing that world you're talking about, and that is a world that I think we're in an opportunity to try to standardize for the state. So go ahead, Moxie.
So I can probably look into the tip 62. I don't know for sure if the person has it, but we'll see. I just wanted to say that I added a question, which is whether we're including EDs and hospitals in the discharge planning when we look at this information. I would love to see payment based on quality in those environments as well. Thanks.
So this is something that I definitely want us to keep wrestling with, because I do think that this group has more than a few times, and rightfully so, talked about kind of the disconnection that exists between our physical health partners and our behavioral health partners in the state, and the challenges of like payment models are so disparate, like everything is so different between those two. Like one of the things that I wonder if there's like a staging of how we even get there, of like, is it or SAM affiliated doctors that start to like build up that. For those of you that aren't aware, we did a series of recommendations in September of 2024 that resulted in a bill in that next session that did not pass. And the reason I'm mentioning it is because that would have required specific prescribing habits to occur within doctors who are treating people with an OUD. And there was a lot of opposition to that bill. It was I will say, like, I was naive in thinking that it would have been a slam dunk when it was introduced, and I think that there's a lot of fears around. Specifically, I think a lot of the fears that I heard at the time were legislation that moves slower than changing science, and I think that that's a good concern to have. And like, how do we balance like the need now with the that problem? And I don't know that, again, I came from behavioral health, so I'm not as averse to regulation, I guess I'd say. So that's why I think your group think is more helpful here than me just controlling the world in that moment. So something that I heard, and I'll just say, like, I'll carry this note into the evidence-based practice work group at the end of this month also, which is like, in our recommendations for the year, it sounds like we need some trainings and support for risk-oriented conversations to occur. So I'm just flagging that now. This is one of the reasons that I wanted that group to exist, is so as these needs pop up, we can very quickly just like figure out what we're going to do there. I can definitely start working on a working definition for this too, to have you review. But one of the things that I just wanted to call out that I think is really interesting here, that I think is helpful, is you've kind of already clarified that. Oh, go ahead, Fernando.
I wasn't meaning to interrupt. I was going to wait till the end. Just ideas around kind of mean and what to also hopefully include, just ideas that pop into my head. Um, Recovery-oriented systems of care methodology definitely says that we have to be involving other systems, educational systems, spiritual practices, cultural practices. I think that because we are leaning into the ROSC framework and what does discharge mean, that we need to also make sure that that is clearly identified with discharge transition planning, having some sort of recommendations around some of those other ROSC kind of perspectives that aren't just traditionally associated with treatment recovery type stuff. So
No, that was something that I was actually going to ask in this kind of closeout summary because I'm noticing time is are there things that are missing from this? ROSC was something that I was going to bring up, so I'm glad that you're mentioning here. Something that I also want to like give people food for thought to think about. One of the nice parts around folks adopting electronic health records is a lot of times fields tend to be repeatable or they tend to be reproducible within a system. So like one of the things we might want to think about leveraging is there any data that is inherently collected as a part of our assessment requirements, treatment planning requirements that are maybe like duplicative, that maybe are kind of self-serving in that place? Because one of the things that I'm realizing you're all talking about is, and I don't want to make the first day of somebody's services more challenging, but like day one though, like somebody could have like an immediate needs risk assessment that be able like is able to speak to a lot of those things that says like over the next 24 hours, like if I return to use, here's what I'll do to be slightly more safe to start leaning into those conversations. That increases time though. And so to think about like, are there existing requirements that might need to also be jostled for us to have a better discharge or transition standard? Like that's something to think about. It'll add to our implementation challenge for what we're trying to do, but does that make it a better thing in the end too? Because one of the things that I and maybe I'm a little like hopeful or optimistic in this. Like I don't think that the solution is going to be entirely like we just rewrote the part of the OARs or introduced like a little bullet paragraph to like how to change discharges and it's fixed. Like I have a feeling it's that conversation, but then it's like the ways that treatment planning is reviewed more periodically. Is it that like a transition plan should be reviewed every 30 days or something that we need to like be thinking about to actually operationalize? Because I think the big fear I have is this document becomes a new buzzword document that everybody just says like, oh, just make sure that these words are in there and you're covered. Like that's what I want us to also avoid in that. I know that's a hard thing, but that's one of the things I think about. Go ahead, Moxie, and then I
Hold
think.
on 1 second. Do we have public comment? Sorry, Mitch. We're same brainwave. That's scary.
I have not received any written public comment, Katie. Thank you.
Thank you, Ashley. Go ahead, Moxie.
Thank you. My question that creeps up now and then is that we often lose our patients to jails. So from hospital to jail or from a clinic to jail. And so when those types of things happen, like if someone goes to the ED or the hospital and then they go to jail, can the discharge planning include what they're to do while they're in jail, what the jail should do to contact the programs, and then when the person gets out, how they're going to resume care? Because so I work in the OTP and we have patients going in and out of jail fairly often. And recently one got arrested and was there for a week. And he said, can you call my OTP? And they never called us, so he never got dosed. So he had a lot more risk coming out of jail without any methadone and with a reduced tolerance. So I'm just wondering how we can kind of keep jails involved in the mix, and include also youth, because sometimes youth are incarcerated and that's pretty risky transition for them as well. Thanks.
Go ahead. Go ahead, Heather.
Oh, sorry, I barely hear you. Can you hear me okay? I'm in a hotel, so I don't know how that. I love that. And I'm always gonna say, can we have a list of, I just want to make sure when we're doing this that we're not putting things in here that are check boxes too much. that could actually be handled through different policy work more effectively, making sure that we're getting the right job in the right place to get the right movement that we want to see. So I'm just going to throw that out there because there's, you know, there's good things that could happen in discharge planning. Is that really the most effective place for that to happen? And to your point, Mitch, about, making a checkbox or admin burden or et cetera. So, building policy around communication across partners might be more effective, possibly. Some of the things that you were talking about data collection and EHR, that's a totally different issue than discharge planning. And that may be handled through a different mechanism than discharge planning in and of itself. So I just ask that we maybe also have a parking lot for things that might be more effectively addressed through a different process, even if it kind of could be addressed through discharge planning, and that we really keep discharge planning focused on client outcomes.
Is that what you were going to say too, Art?
Yes and no. Yes, actually, it's just the sequential intercept model. I think it's something that is being used a lot on the East Coast. As far as the West, with Seattle, Oregon is starting it with the deflection. We're doing it with diversion, but I'm not seeing that written anywhere within OHA. But yet, the state and the county and the cities are moving in that direction. And I don't want to speak for Allison, but I think at least for me, it reflects where some of those care coordinations can happen that, again, don't live in that other place. It's just a part of coordinating together.
Thanks, Art.
It looks like someone had a last minute public comment to make. Go ahead, Rachel.
Thank you all. Sorry, I've been your lurker for the last several meetings from OJD. I'm our treatment core analyst and really appreciated the conversation and super interested in discharge planning as a previous practitioner in a community was always a challenge, and just appreciate everything that you all are thinking through. To the last comment, I think, Moxie, that you had put out there of just this kind of how you coordinate with the jails. I really, really appreciate the flagging on that. And I was hesitating throughout this whole meeting of whether or not I should ask to make a public comment. A lot of times your justice system partners are phenomenal at helping put together some of these recovery oriented plans that we can be a part of helping with those connections. We can receive them and hopefully they don't even have to go back to jail depending on the circumstances. So yes, absolutely. Please, let's make sure people are getting the medication they need and all of that stuff when they're going to jails. But also we are very, very interested in partnering with you all. And I think that I can say that from a justice system perspective generally, but in my specific role in the treatment court world, like we are here for the work we're doing and we want to supplement it and help these people be successful when they get home. So thank you so much for the opportunity.
Thank you, Rachel. And you're always welcome to lurk. We like a good lurker around here.
Really quick, Katie, before you close this out, next month's meeting, I will come with kind of working draft of what you've all done. I'll digest something into something cohesive. I just didn't want to spend this introductory thing having you wordsmith a list of OARs. It felt better to start from a paragraph of things for us to figure out. So thank you. This was very helpful to that process, and I think will make for some fun summer work for us. And also y'all are, I think, the only committee that had availability for both months in the summer. So I don't know what that is about, but thank you also. Back to you, Kate.
Mitch, we need to review what fun means to you. But so thank you everyone for another thoughtful discussion. And I appreciate the perspective each of you brings to this committee. Conversations like today's help ensure we're looking not only about policy, but also about what successful implementation looks like across Oregon's diverse communities and systems of care. I also want to thank Mitch for preparing today's presentation and helping facilitate the discussion. And if there's nothing further, we'll adjourn today's meeting. And everyone have a wonderful afternoon.